Entonces ahora vamos a entrar.
Well, okay. Well, we're going to move on to another subject. And we have here with us this afternoon, and from across the ocean, we have Joseph Standford with us. And Joseph Standford is somebody that has lots of prestige in terms of natural fertility awareness. He's a family doctor, but he's a professor, and he's the director of the Office of Reproductive Health of the Department of Medicine, of Family Medicine and Preventive Medicine at the Department of Medicine of the University of Utah in Salt Lake City. He's an assistant professor of the Departments of Gynecology and Obstetrics, and perhaps the most relevant thing is that he's somebody that has made a very big effort to try to summarize and to publish evidence on the efficacy of these natural fertility awareness methods. And we want him to, well, this is a very characteristic issue. What is the scientific evidence of the efficacy of natural fertility to space out pregnancy? So with you this afternoon, we have Professor Joseph Standford from Salt Lake City. Whenever you want, please go ahead.
It's a pleasure to present this talk on effectiveness of fertility awareness-based methods to space pregnancy. I appreciate the opportunity and invitation to speak to you, and look forward to the discussion. I will go over some background and spend some time on a systematic review of fertility awareness-based methods that I participated in, including the quality criteria, the perfect or correct use pregnancy rates, the typical use pregnancy rates, and then give a few perspectives on these rates and conclusions and follow up with some recommendations for future research as well. So for background, I would like to keep two questions in mind, and I will come back to these at the end of the presentation. The questions are, how can the pregnancy rates during use of fertility awareness-based methods be fairly evaluated and communicated to couples or clinicians who wish to compare different FABM or contraceptive methods? And the second question I have to consider, what are the pregnancy rates in FABM studies and what influences them? So let's talk about the pregnancy rates for a moment. These aren't all the possible pregnancy rates, but these are some selected important ones in fertility awareness-based studies. You can have the total pregnancy rate, which is all pregnancies during the study, regardless of the intention of the use to avoid or to conceive. And the denominator for this is all cycles or all months. This is not always reported, but it's a very important piece of context for any fertility awareness-based study or population. The next one is the typical use pregnancy rate, and this is what is more standard in contraceptive or family planning efficacy studies, and that's why we look at it to compare across studies. This is all pregnancies occurring with the intention to avoid pregnancy, and the denominator, again, is all cycles or months with intention to avoid. There is a rate that has been used in a lot of fertility awareness-based studies called the method-related pregnancy rate. This takes, the numerator for this rate is pregnancies during correct use to avoid. The denominator is all cycles or months. This, however, is not a good rate to use because it can be seriously distorted, artificially reduced, if there are more cycles where the method is not used correctly, and this will increase the denominator without increasing the numerator. So I will not report these rates, but I do report it here on the table for historical reference, because many FABM studies have used this rate. And then finally, there are correct or perfect use pregnancy rates. This is the numerator is pregnancies during correct use to avoid. The denominator is cycles or months during correct use to avoid. Now, any of these rates could be calculated in different ways. They can be calculated with a Pearl rate, or with a life table, or with a Kaplan-Meier. There are different statistical ways to do it, but the fundamental principle is which pregnancies are in the numerator, which cycles or months are in the denominator, regardless of what statistical method is being used. So now onto our systematic review. This was published in 2018. I was privileged to be a part of a good team. We had a spectrum of people, some who had a lot of experience with fertility awareness-based methods, some who were relatively new to the area, clinicians, epidemiologists, demographers working together for, I think, what was a good systematic review. And I'm going to present some highlights from that. In this systematic review, we focused on these two pregnancy rates. The typical use pregnancy rate, which is during use with intention to avoid pregnancy, and the correct or perfect use pregnancy rate, which is pregnancies occurring during correct use to avoid and cycles with correct use to avoid. We did not look at the total pregnancy rate, although we recommended for high quality that studies do report that. And we did not look at the method-related pregnancy rate because it is, and it can be, a flawed or biased approach or measure. We developed some quality criteria. There were 13 quality criteria overall. I'm giving you the highlights of them here. For high quality studies, the most commonly met criteria were that we had a clearly defined method of fertility awareness-based fertility awareness, or NFP, that the study duration was 1 year or more, and that the population of users was well described, which, as we'll see later, is important for context. The least commonly met high quality criteria were to evaluate intercourse in each cycle. When intercourse occurred, did it occur during times of fertility or not? To follow up closely to detect pregnancy as opposed to just reporting it, and to define reproductive characteristics of users, and to assess the intentions in every cycle, which is necessary for a correct use, for a rigorous typical use analysis. For the low quality criteria, the most commonly failed criteria were that pregnancy in many studies was self-report only, not even looking at the chart. The statistics were often not described. It was often not described how many users were new versus already established users. And the inclusion criteria were often not described. And over half of the studies failed at least one of these low quality criteria. So these are the summary results of typical use pregnancy rates from the systematic review. The scale down here is pregnancy rate per 100 women years. We have 10, so here would be 10 pregnancies per 100 women years, or you could think of it as a percentage, 10%, and then 20 per 100 women years, and 30 per 100 women years. These are the typical use during use with intention to avoid pregnancy, new users only. And so we have here the standard days method, which is a calendar method, in the range of 10-15%. The 2-day method, mucus method, in the range of 14%, 13%. Cervical mucus methods, including Marquette cervical mucus, Billings ovulation method, they range from a low of around 4% to a high of around 30+%. And then we have this natural cycles, which is a temperature-only method. Since come out with a new study in 2021, is not on this in review. That is similar rate. Symptothermal single check and symptothermal double check, particularly Sensiplan, which is the German version, symptothermal, with the lowest rate here and around 2.8%. The I think it's 1.8%. That's off the top of my head. We have the Thyma methods, the another symptothermal method, and then we have the Marquette monitor methods down here, which all are in the range of 2 to 5 or 6, 7%. So if we looked at correct or perfect use pregnancy rates during correct use to avoid, there were much fewer studies that reported this. As I mentioned before, many studies reported a method-related pregnancy rate, but that is a distorted measure or can be a distorted measure. So we looked just at the correct use pregnancy rates. And the scale here is different. This is 5 per 100 women years at this point. So all of them were under 5 per 100 women years, except for Persona, which is sort of an outlier. It's a device that is actually no longer available in the version that was studied. So it is available, but it's been modified. So that's an outlier. But these other methods of standard days, cervical mucus, Billings ovulation, Sensiplan, which is symptothermal, which is less than 1% here, and the Marquette, which was at 0. This has no bar here because it was 0. You also see the number of women or couples in each study here. Our conclusions from the systematic review was that there were no high quality studies. In order to be a high quality study, the studies had to meet every high quality criterion. Some people may think we set the bar too high, and that would be a debatable point. There were some studies that were missing only 1 or 2 of the criteria. There were about 40% of the studies were moderate quality. The typical use pregnancy rates had a wide range, and that is to be expected, as I will show in a moment. The correct or perfect use pregnancy rates were all under 5%, and some were under 1%, the dual indicator methods. The exception was Persona, which is an outlier and is not available in that form anymore. And again, possibly the lowest correct use pregnancy rates were for the dual indicator methods. I mean, that's methods that have 2 ways of indicating the start of the fertile window and the end of the fertile window. Typically, for the start of the fertile window, it's either the monitor or mucus plus a calendar calculation. And for the end of the fertile window, it's either it's mucus plus temperature or mucus plus, or monitor plus mucus. So there are a couple of different, but dual indicators, or sometimes it's a hormonal check. So a couple of perspectives on these results. It's very important to emphasize that typical use pregnancy rate is not a single number. And I disagree with some of my contraceptive researcher colleagues on this who think that you can come up with a single number for typical use. But that's absurd because typical use pregnancy rate depends on the population. It depends on the population's demographics, their relationship, their motivational factors, and these all may be more influential than which method they're using. Here's one example of this. This comes from an old fertility awareness-based method, temperature-only method, from John Marshall's study. They looked at women stratified by age. These were married couples in the greater London area. From 20 to 24, these were the unintended pregnancy rates, so they stated they had the intention to avoid. The pearl rate was 28, or about 28% in approximately in a year. The 30 to 35, 9-year-olds, less than 1%. That's a 30-fold difference. It's not because women who are 35 are 1/30th the fertility of age 20. There is some drop in fertility, but not a 30-fold drop. This is based on the women's motivation, their relationship, how many children they have. And I'm not going into it because of time, but if you look at the original study, you can see this because they find the same pattern by duration of marriage, the same pattern by number of children they've had. So it's a matter of the demographics and motivation, not a matter of biology for this typical use pregnancy rate difference. We also need to remember that unintended pregnancy says nothing about wantedness of pregnancy. So an unintended pregnancy can be very much wanted, and usually is for fertility awareness users. So recommendations from this set of work and I want to go back to the questions. How can the pregnancy rate steering use of fertility awareness-based methods be fairly evaluated and communicated to couples or clinicians who wish to compare different methods? Part of my answer to that is, for fertility awareness-based studies, all pregnancies should be reported, the unintended and intended pregnancies. Now, I did not show you that from our systematic review because we did not have that in the paper. And it actually was a minority of studies that did that. Only a handful of studies looked at a total pregnancy rate to include intended pregnancies. But that's an important piece of context to understand the motivation, characteristics, and demographics, the type of population you're dealing with, the dynamics of their use. The intention should be measured in every cycle, the beginning of every cycle, and that's how you get a typical use to avoid pregnancy rate, is looking at the intentions in every cycle. I mean, that's the best way to do it. Other studies did it by just measuring it at the beginning. I think that's not as realistic for how couples may change intentions. All cycles should be evaluated for correct use, not just pregnancy cycles. And this is key. One of the innovations of some fertility awareness-based studies, particularly the Billings method, the Creighton method, and also Creighton model fertility care, and also the Marquette method, is to do a pregnancy evaluation. And that's an important piece of information. It tells you about the pregnancy. But if you want to get a correct use pregnancy rate, you need to have an evaluation for every cycle or every month, not just for the pregnancies. Question, what are the pregnancy rates in the fertility awareness-based studies? I've shown you the overview of our systematic review that went through 2018. There have been a couple of studies published since then, so hopefully we can update it at some point. But what influences those pregnancy rates? So part of my answer is that fertility awareness-based studies should assess desires, demographics, reproductive and motivational characteristics of users, and we shouldn't have this illusion that there's just some platonic single number of what a typical use is for a method. It just doesn't exist. It's based on the population and the motivation and characteristics of that population. Any concomitant use of barriers of withdrawal needs to be assessed. Now, I did not have time to go into this in this presentation, but in some of the studies I've been involved in, if we look carefully and ask about barrier withdrawal use, it happens in the studies I looked at about 10% of cycles. It could be less, it could be more, but it's enough of the cycles that we can't ignore it if we want to have a full picture. So if you just pretend it doesn't happen, you're missing some of what's going on. And then also, we need to look at measures that are specific to fertility awareness-based methods. It can be informative in understanding how these methods are used. For example, in the Creighton model, there's a concept of achieving related pregnancy rate. I think that's a valid concept. It's a valid and good rate to report, but it is not comparable to other studies at this point, except perhaps 1 or 2 billion studies may have done something similar. So if there are questions or comments, I will look forward to receiving those either during the meeting discussion or by email. Thank you very much.